you had to do a little bit of reframing how we approach disease, that it's not necessarily about visual acuity, but more so about the quality of vision that you have.
Welcome to Season 6 of EyeCan, a podcast about ophthalmology through a uniquely Canadian lens. EyeCan is co-hosted by me, Patty Sahed, and Heather O'Donnell. Throughout the season, we'll have guest co-hosts for some of our shows. We will share our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers. Season 6 of EyeCan is brought to you by Astellas Pharma Canada and Johnson & Johnson Vision. We thank them for their support.
Hi, everyone, and welcome to another episode of EyeCan. Today, we're discussing developments and innovations in geographic atrophy, an advanced form of age-related macular degeneration that significantly impacts vision and quality of life. Joining us is Dr. Deepa Yoganathan, who brings deep expertise and insight into retinal disease and patient care in Canada. Born and raised in Montreal, Dr. Yoganathan earned a BSc in physiology from McGill University and her medical degree from Albany Medical College. She completed her residency at North Shore Long Island Jewish Medical Center in New York and a vitreoretinal fellowship at the University of Toronto. With 15 years of practice in the U.S. and Canada, she currently works in Windsor and Detroit and holds academic appointments as assistant professor at the University of Toronto and associate professor at the Kresge Eye Institute, Wayne State University. She also earned the Royal College of Physicians Educators Certificate and a Master of Science in Health Research Methodology from McMaster University. Dr. Yoganathan is a co-chair of the Canadian Ophthalmic Imaging Symposium, serves on the board of Fighting Blindness Canada, and reviews for the Royal College board exams. She directs the Quality Improvement Fellowship at Kresge and co-chairs the History of Retinal Division for the ASRS. A dedicated educator, she received Teacher of the Year awards in both 2010 and 2025. Her interests include retinal trauma, diabetic retinopathy, patient advocacy, systems navigation, and practice efficiency. Dr. Yoganathan, welcome to EyeCan. We're really excited to have you.
Thanks for having me, Hattie.
So, as the glaucoma specialist, geographic atrophy, which is our topic today, has been a topic that, I for years have felt limited in terms of what I can offer patients in terms of treatment options and hope. And I know that things have been changing and that there is hope kind of around the corner. But I certainly, as a glaucoma person, don't have a full grasp of that. So I'm particularly excited about this chat because I think you'll be able to enlighten me and our listeners about what's around the corner for geographic atrophy. So, for a long time, it's been considered an area of significant unmet need in terms of not having promising options for treatment. And so can you share from your perspective how you feel the current treatment era in Canada has changed and how it compares to where we were a number of years ago?
Thanks, Hattie. That's a very good question. I think right now we're in a very advanced development in medical retina. As you mentioned, geographic atrophy has really not been given any attention since, for the first, I've been in my career for 15 years. So let's say the first 10 or so years of my career. And now all of a sudden that is the focus. So anti-VEGF treatments became available in 2005, 2006. And that was such an exciting time in retina. We all, jumped on board across the world to start treating wet macular degeneration, diabetic macular edema, vein occlusions, conditions that people oftentimes went blind, and now many people's visions were saved. And I think people have definitely gotten a handle on treatment of all of those kinds of diseases. But it was very frustrating that you could be treating very successfully the fluid in a patient with wet macular degeneration, but they may still go blind. And so why would they go blind? Because their dry macular degeneration was advancing. and that has its own timeline in terms of risk of blindness. So what exactly is dry macular degeneration? Why does it cause vision loss? Well, there's a certain type of dry macular degeneration called geographic atrophy. Geographic atrophy is basically the loss of photoreceptors, your rods and cones, your retinal pigment epithelium, RPE. And when you lose that tissue, you don't get it back. And so patients, you can be telling a patient, yeah, you're doing so great. We can extend your injections now to 20 weeks because the drugs have advanced for anti-VEGF treatment so far. Well, doc, why am I still not seeing any better? And for many years, we had no hope for change with that, and now we do. Now we have a huge advances in the treatment of dry macular degeneration, specifically geographic atrophy. And so, what are those treatments? Well, there's a category of drugs called complement inhibitors, and that helps to reduce the progression of geographic atrophy. It doesn't reverse geographic atrophy, but if you identify the appropriate patient, you could help reduce their loss of vision long term. And this is really important. 5% of patients over the age of 50, so 5% of all persons, over the age of 80 have geographic atrophy. So that is, a lot of patients. If 2.5 million patients have macular degeneration in Canada, the amount of patients that have geographic atrophy are a lot. And every year that you get older above the age of 80, your geographic atrophy grows 2 millimeters, which is a lot. That is a lot of tissue loss in the retina. So in general, we are really at an exciting time where there's new treatments, and hopefully they will be approved soon in Canada.
So that's exciting. And can you tell us more about the approval process in Canada and what's being integrated in terms of the newer therapies that you refer to?
Yeah, so approval process is complicated in Canada. There are two companies in Canada. One was Apellis and one is currently Astellas. Apellis went to Health Canada to get their drug Syfovre approved. They were ultimately rejected. Astellas is the company that has a drug called Itzervay. Both of those drugs are widely used in the United States, by the way. And so we're hoping that Health Canada will approve Itzervay in Canada so that Canadians have access to a drug that many North Americans have access to. I think in terms of your question had to do with Health Canada approval and regulatory. So part of the challenges were that we had to change the conversation between improvement in vision or stability of versus stability of imaging. And so again, back to our anti-VEGF era where we're treating diabetes and wet macular degeneration and vein occlusions, so many of those patients actually improve vision. After the first 3 injections, they could improve as much as multiple lines of vision, which is pretty amazing in retina. And a lot of them would keep a decent amount of vision gain. And so in dry macular degeneration, we're no longer talking about visual acuity. We're talking about progression of a disease in an image. Therefore, multimodal imaging is the important way to approach how progressing a patient is. And so when these companies were approaching Health Canada, this nomenclature and this terminology were new, and you had to do a little bit of reframing how we approach disease, that it's not necessarily about visual acuity, but more so about the quality of vision that you have.
One of the things that I've always been impressed by in terms of your approach to patients is the way you talk to patients about their condition and your attempts to kind of reassure them and also make sure they understand what's going on. And so, one of the things that comes up in my practice with patients that have a diagnosis of macular degeneration before I send them off to a retina specialist colleague is kind of the difference between dry and wet. And I think there's like a perception that dry is better, but then dry is not really treatable yet. And so, but then you can also have wet with dry at the same time. And so, do you have like a spiel you can share with us that you share with patients to help them understand that?
Yes. So if a patient comes to me and they have new wet macular degeneration, in that first conversation with them, I say, you've had dry macular degeneration all this time, and now in this, let's say in your right eye, now you have a new additional diagnosis of wet macular degeneration. Most of the time, patients think the dry converts to the wet, but that is allowing them to think that the dry has disappeared. And that's not true. The dry is underneath and progressing at its own timeline. And so I think in that initial conversation that, now we're going to start treating you for your wet macular degeneration. You can also take the opportunity at the same time that you are teaching them about the tools that they need to use for the wet macular degeneration, which means injections that we oftentimes start the same day, and AMS or grid. That's another preventative action that they should take to be able to detect earlier their fellow eye. And that's something that the optometrist, the ophthalmologist, and the retina specialist can all do. I think another opportunity is to educate them that we will also evaluate the level of their dry macular degeneration to see if they are candidates for any of the new treatments. Even if they're not currently available in Canada, it is important that we gauge who is going to be a candidate. Why? Because when the drug is available in Canada, the complement inhibitor for geographic atrophy, there's going to be so many patients that we need to now identify who should be treated. Not everybody with dry macular degeneration is going to be treated. So if we can identify a timeline of, oh, this person's geographic atrophy is really advancing quicker, or whether they have multifocal disease, or whether they have non-foveal disease, these are all risk factors that we can identify that say, hey, you're going to progress quicker. You would be an ideal candidate for this new drug. And so the conversation has gotten a lot longer for me because now we're not just talking about the wet macular degeneration. We're also talking about the dry macular degeneration and the levels of multimodal imaging and the levels of screening and the homework that we put on the patient to be able to identify changes in vision in order to communicate with us if there's anything new going on.
It definitely sounds like there's more layers to the evaluation now. So, are you at the point where you're kind of labeling patients as good candidates for treatment that you're expecting to be available in Canada? Or do you feel like we're not there yet, but you just have to have that in mind for the near future?
Oh no, absolutely. We are identifying patients. Actually, even my techs, my assistants, my scribes at in my clinic, they will open the autofluorescence from a few years prior, a year ago, and now, and they'll draw their attention because it's so easy to see on an autofluorescence the progression of geographic atrophy. So someone who has no medical training in the sense of is not a doctor, is not an optometrist, is not an ophthalmologist, it is so obvious to them which patients are candidates for the new treatments based on the history of progression.
You had referred to multimodal imaging a few moments ago, and I'm wondering beyond, the pharmacologic treatments that we've discussed, What innovations are happening in the imaging and diagnostic technology space that are helping you as a specialist detect and monitor geographic atrophy better than you were before?
Yeah, so there is, so basically, multimodal imaging, including autofluorescence, OCT, these are two of the mainstay imaging tools that we use to evaluate the extent of disease of, for example, geographic atrophy that allows us to create a map of where it's extending. We can look at, very minute structures in the OCT that identify which lesions are growing or not. There's additional tools like OCT and geography that allow us to detect maybe some choroidal neovascularization that is hiding underneath the RPE or the retinal space. And so what are some of the newer treatments that patients may be hearing about nowadays? I would say there's three. One is called Macumira. This is a company that is Health Canada approved a couple of years ago. I believe this has been done about 4,000 times, 4,000 treatments in Canada. This is a microcurrent technology that is delivered to the retina to energize some of the cells, parts of the cells in the back of the eye. You can see this kind of technology in other fields like dermatology, where they're approaching rejuvenation in the same way. Patients oftentimes ask about red light therapy. These are devices that you could actually purchase on Amazon. And as you've heard about red light therapy again in dermatology or other fields, where there is the hope that it improves the cells in the retina. And we have seen cases. We've had presentations of cases at meetings where patients not just their vision has improved, but their anatomy has improved. And the treatment that has the most amount of clinical trial data, the clinical trial was called LightSight, and that was done in the United States, and the device is called Lumathera Valeda, and that is FDA approved. It is not Health Canada approved, but the device was recently purchased by Alcon, and so Alcon is in Canada, and therefore we may be hearing about that more. And so there are many physicians in the US that are doing that treatment and believe in that treatment. And again, these are non-pharmacologic treatments, but there are definitely new treatments and early adopters of all of this technology. Obviously, longer clinical trials or a more robust clinical trials would be amazing for any of these treatments. Unfortunately, large dollars oftentimes depend on large national organizations or endowed pharmaceutical or device companies. And so it's not something that we can necessarily perform ourselves.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
I'm Devish Varma. I am the Medical Director and CEO at Prism Eye Institute and the Executive Vice President for Clinical Ophthalmology at Vision Group. And I listen to the EyeCan podcast.
In conditions where, the impact on vision is so devastating, patients can be so desperate sometimes to just try anything. So my guess is that you certainly have patients that come to you and say, Doc, what else can I do? What else can I do? I'm happy to travel. I'm happy to pay. whatever. And so of the three treatments that you just mentioned, so I heard you say Macumira, red light, and then the new Alcon acquisition. Are you currently, routinely sending patients for any of these treatments? Are you waiting for more clinical evidence? What is the current approach in your practice or in the practice of other retina specialist colleagues with regards to these three new treatments?
I don't have access to Lumithera in my Detroit practice at the moment, but my colleagues are interested in acquiring a device, and it's not available in Canada at the moment. The red light therapies, I don't know enough about them to offer them or acquire them. However, Henry Ford is purchasing, multiple, that's another center in Detroit. They're purchasing multiple red light devices and are going to try multiple, to see what the differences are, test them and things like that, because many are available. Macumira, my office does offer a Macumira. When I discuss it with patients, I tell them the number of times it has been done, the fact that there's no clinical trials, the fact that we don't know long-term success rates. But I think that there are patients who, like physicians, are early adopters and, as you said, want to try as much as they can. And if we haven't identified side effects in a treatment thus far, then I think it's really the patient's decision whether they want to pursue available treatment. Again, as long as we don't feel like we're doing harm. And so I think all we want is data. We just want more data. And I think over the next year, we should be able to not just acquire, but publish, unbiased data. And I think that will go a long way in terms of better understanding how to incorporate these technologies into the discussion. I'll take it a step further. There are stem cell treatments under investigation in the US, and there are certain centers close by in Ann Arbor at University of Michigan, which is only, an hour from Windsor, that have clinical trials on stem cells. So, patients are very well educated. They do the research themselves. They are on chat groups. They share information. They are constantly sharing. And so patients advocate for themselves and come into my office asking for treatment that they figured out themselves. And so I think it's important to know about all of these advances in the medicine.
So a lot of these treatments have gone through extensive clinical research to get to approval. And what can you tell us about how Canada has contributed to these advances in geographic atrophy in terms of participation in research?
I think there's a lot of, retina specialists who are interested in the topic. I would say that there's been definitely a mental shift in when these pharmaceutical agents first came on the market, maybe 3 years ago. At the beginning, there was a lot of skepticism, a lot of hesitation, and I think that has changed significantly. Number one, partially because some of the physicians in Canada participated in the clinical trials. So they saw patients who one eye kept their vision and the other eye, who wasn't in the trial, went blind. And they have patients who are begging to get the drug in Canada who don't have access to the drug. And so I think that there are people who were sort of forced to get exposed to the success of the drug because they were involved in clinical trials and they got to see the advances firsthand. And I think, secondly, there are retina specialists who frequently go to meetings, are consultants, interact with the doctors in other countries who are using the drug regularly. And I think the more education and the more exposure and the more real world experiences allow you to feel more comfortable with new drugs.
Yeah, that sounds great. It's great that Canadians have been participating in the trials and one contributing and two kind of sharing their experience with their regional colleagues. From a patient perspective, though, what do you feel are the most important unmet needs for geographic atrophy that still exist? It sounds like at the very least is at least the approval process in Canada. That would be one big unmet need. And beyond that, where do you feel like the unmet needs are and where future innovation needs to head?
I think that access in Canada, it can be challenging. So, who is the caretaker of the patient with dry macular degeneration in Canada? All levels of care within the eye space, optometrists, comprehensive ophthalmologists, retina specialists, everybody is busy. So I think in terms of an unmet need is how are we going to identify these patients who are candidates if the patient doesn't have symptoms? If a patient has symptoms of vision loss, oftentimes that's a little bit starting too late. And so I think generally, if patients start to see their regular eye doctor every 2 years just to get a checkup, I think they can start getting properly educated about what their diagnoses are. And from there, with the new advancements of these technologies, the whole referral process will change. So now, the optometrist generally would keep a patient with dry macular degeneration as a routine follow-up with education about when to detect wet macular degeneration. But now the patient would be referred earlier, again, to assess their level, degree, and advancement of the dry macular degeneration earlier with either the comprehensive ophthalmologist or the retina specialist.
So does this change sound scary to you as a retina specialist and provider, or are you excited about what's happening in geographic atrophy care over the coming years?
I think it's very exciting. I think it's
Hmm.
like it's energizing that when a patient comes in and they have read all of the material that we have given them in advance, which is what I do now if patients are coming in for consultation for treatment in dry macular degeneration, we give them all the information ahead of time. So they've read everything I want them to read. They come in asking like really interesting questions, some of which, I'm happy to answer and some of which I don't know the answer to. And so it's really thought-provoking and exciting to be able to have these like additional conversations with the patient and getting them to think about what their options are and what they want to do. So, of course, it's very easy to talk about burden and it's very easy to talk about busy clinics and how many late hours we work. But at the same time, it's for a good reason that there's new technologies and new education to be had for both us and for the patients.
Awesome. And as we wrap up this conversation on geographic atrophy, you're in it. You're in these conversations at conferences. The fact that you practice in both the U.S. and Canada, have access to these treatments sooner in the U.S. than the rest of us in Canada. But for other people that are not necessarily kind of drowning and participating in this space of geographic atrophy and the new technologies, is there anything you feel they need to know now to be ready to send the appropriate patients instead of seeing them on an annual basis for dry AMD? Is there anything they need to know now? If you were to summarize kind of main learning point that everybody practicing comprehensive ophthalmology and seeing the occasional dry AMD patient needs to know already in 2026?
Absolutely. I think performing an autofluorescence, so many doctors already have a camera, but they may typically use color photos and not necessarily autofluorescence. So use that autofluorescence. It is typically very easy to understand if a patient does have geographic atrophy. Some tricks to that are if you're looking at the fundus image, they may have a patch where you're seeing the choroidal vessels. You should not be seeing the choroidal vessels so obviously when you're looking at the macula. There could be a patch of RPE missing in that area. Autofluorescence in those spots will look black. Black means they're missing their RPE. So doing the pictures more often will make you more adept at screening the patients earlier. And then secondly, understanding which patients are at higher risk of advancement. So a clear risk factor is multifocal disease. So if they have a bunch of little black geographic spots, geographic atrophic spots circling the fovea, those are the patients that will advance most. All those little spots will coalesce into one large area of geographic atrophy. And so you want to identify them and hopefully give them treatment before that atrophic area has entered the fovea. And you can take a patient who has 20/20 vision, no symptoms whatsoever. Their entire macula is black except for a tiny little spot in the center. And that patient is about to lose their vision. And those patients are the ones that you could really save for years to come and add years of vision to their life.
That's so useful. Thanks for sharing that, Deepa. So now to move on to our lightning round, which is a favorite part of the episode for some of our listeners, and a way for us to ask you some unfiltered questions to get to know you a little bit better. I wanted to start with a question about your holiday habits. So when you're on vacation, are you more of like a chiller, laying down on a lounge chair, or are you more of a go, 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 running around town, exercise, hiking, whatever it is? What's your holiday style?
I think it depends where I am. If I'm at a beach resort where there's nothing to do but sit in the sun and dip in the ocean, I'm totally good with that. We did a trip to Sicily last year with my kids, ages 6 and 8 at the time. And we just explored, my husband's likes driving, and we drove all around Sicily for a couple of weeks and just stopped off in random places. In the middle of our car ride, found a beach or found a beautiful mountain, hiked a volcano, so many different things to do and be spontaneous, depending on the location. We have an upcoming trip to Costa Rica, which will probably be more adventurous. And I don't even know if we're going to get to a beach. So I think it depends on where we go.
I love that. Sounds like I need to talk to you about travel. The second question is related to you being cross-border, which is not really a common reality. So, are there any things or activities or things you buy that are unique to when you're in Canada versus US?
Poutine, poutine, of course. Even though it's made in Ontario and not Quebec, it's
Mm-hmm.
still comfort food for me, and I'll still order it as much as I can. Actually, in Michigan, they do have a lot of poutine. There's a lot of restaurants that offer it as an appetizer, actually.
Yeah. Anything that you only do in the US?
Yeah, I can't think about anything that I only do in the US.
Yeah. Well, interestingly for me, there's certain things I can only order in the US because it's more complicated to bring it cross border. So certain, I don't know, certain things that are not available for purchase in Canada, I'll buy it in the US.
It's probably
But
easier to buy California cab wines in the US than it is in Canada.
there you go. There's your US only purchase. A third is about parenting. We often talk about our kids. And so do you have any parenting hacks that you want to share? Any favorite parenting hacks?
Oh, I wish I could have parenting hacks. I think one thing that we really adopted when we were young was when the kids were in their toddler phases and, a little dysregulated, is regardless of if they were upset or mad or anything, we always encourage them to ask for a hug. And so even if they were storming off or upset, we would offer a hug or we would ask them to always come to us with a hug. And I always found it so interesting that they could be so mad and so frustrated, but still what made them feel better was to be able to reach out to us and get a hug, even though they may feel that they may feel shy to ask in a way that because they were just, storming off. And so I really appreciated that we instilled in them that it's okay to have all these emotions, but at the end of the day, we're still going to be there standing right next to them and ready to hug them whenever they're ready for it.
That is so great, Deepa. And there's this motto that I try to keep in my head at all times. I'm sure you've heard before, which is to connect before you correct. But the challenge with that is operationalizing it, right? And you just found a great way to operationalize that motto, right? So even when they're going crazy and they, need help and guidance and to be corrected in some way, you have that automatic way to connect before you do that. So I think that's amazing. That's a great parenting hack. You need to popularize this. I'm sure there are lots of parents of young kids out there that need to hear that. And so do they still do this now at the age of 7 and 9 or not anymore? Yeah.
No, I think they do. We don't talk about it the same way. I think I just offer it, but we always allow them to have a moment. Do you need a minute? Do you need, private time? That's good. We're going to be waiting for you when you come back.
Well, what a great way to wrap up this conversation, Deepa. Thanks for sharing your time and your insight on a really important topic, which is geographic atrophy. I think it's really exciting to know that there are more options for patients really around the corner in Canada, and you help kind of provide the context on how we as ophthalmologists can identify those patients and guide them towards treatment providers, hopefully in the near future. So thanks again. That was wonderful.
Thank you, Hattie. Thank you for having me on the program. I appreciate the opportunity.
Thank you for joining us for this episode. We look forward to bringing you more engaging content over the coming months.
Merci de vous être joint à nous pour cet épisode. Nous avons hâte de vous proposer d'autres contenus captivants au cours des prochains mois.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Thank you from the Canadian Ophthalmological Society.
Merci de la part de la Société canadienne d'ophtalmologie. Our sponsors for season 6 of EyeCan are Astellas Pharma Canada and Johnson & Johnson Vision. We thank them for their support.
EyeCan is available wherever you listen to your podcasts and, of course, through the COS Practice Resource Center.
EyeCan est disponible partout où vous écoutez vos balados et bien sûr au Centre de ressources pour la pratique de la SCO.
Listening to EyeCan counts for unaccredited MOC credits. Listeners may claim 0.5 credits per hour under Section 2, which is individual learning as educational content review, and that can be done up to 30 credits per year.
EyeCan is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
EyeCan est écrit et réalisé par Kim Teitler et produit par John Allaire d'Allaire Strategic Works. Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more. Certains épisodes de cette saison incluront des liens pertinents dans les notes d'émission, alors n'oubliez pas de consulter les descriptions des épisodes pour en savoir plus.
If any of our listeners have topic ideas to submit, please email them to communications@cos-sco.ca, and we will review for consideration.